Just want to get started by sharing a little bit about some context. So first of all, this news conference will be recorded and we'll share it on our social media platforms. We will also send out follow-up notes to media with Q&A following the news conference. So the format will be brief opening comments, which will be followed by questions from media. And just to give you a bit of context, in the Southwest region, there is a pandemic leadership structure that supports assessment, stabilization, crisis response for support to long-term care homes, retirement homes, and hospices. And it's led by a sub-region triad, and ours is here on Perth, as well as the Southwest triad gets involved as needed. So those tables include sector representatives from hospitals, primary care, public health, and community. And today we have some representatives from the Huron-Perth sub-region triad pandemic leadership table to speak. Andrew Williams, who is President and CEO of Huron-Perth Healthcare Alliance, who is also the Huron-Perth Pandemic Leadership Hospital Lead, and Dr. Paul Gill, who is a primary care physician, who is the Huron-Perth Pandemic Leadership Primary Care Lead for the sub-region triad table. And from public health today, we have Dr. Miriam Clausen, who is our Medical Officer of Health for Huron-Perth Public Health. We also have others with us today who can answer questions. Jeff Renaud, the Huron-Perth Pandemic Leadership Community Lead, and Mike Adair, who is the Chief of Perth County Paramedic Service. So we are going to start this morning, though, with comments from Lily Goodman, who is the Chief Operating Officer with All Seniors Care, the company that operates Cedarcroft Place. So Lily, I'll hand over to you. Rebecca, do you see Lily? Is she on mute?
I will check.
It looks like you are on mute.
I saw her name.
Can you hear me?
Now Hello? We can. Yep, thank you.
Sorry about that. Yep.
Okay, that's fine. I am Lily Goodman. I'm the Chief Operating Officer of Cedarcroft Place Retirement Home in Stratford and All Seniors Care Living Centers. We're here today to update you on the COVID outbreak at Cedarcroft Place, which is a retirement residence that we own and operate. To give you some background on the situation we currently face, one of our residents tested positive for COVID-19 on October 29th. COVID has hit our residences and our residential home hard and fast. As of this morning, there's 42 positive cases in our residence and 18 in our staff. We have lost 4 cherished residents to this outbreak, which is heartbreaking. This is a very difficult time for our residents, their families, and our staff. I want to give you a sense of Cedarcroft Place. It is a small retirement home residence with 85 suites for individuals or couples. Cedarcroft Place is a caring residence where people become neighbors and families. We are a family-owned and operated business, and we apply these family values to the way we operate. Some of our residents have been with us for as many as 10 years, and this is their home. They joined us as a healthy retiree and have stayed with us as they've aged, and in many cases, they stay with us when they are in palliative care. We believe this is a good model for aging. Since October 29th, we have been working with local public health, community, and medical partners to assist our residents. It has been heartwarming to see this unprecedented response and cooperation. This has included providing us with much needed staffing, which is challenging during this outbreak. You will hear from other speakers, but in general, some residents are moving to hospital. We are all united in wanting to achieve the best possible health outcomes for our dear friends. And we want to sincerely thank public health and medical partners in Huron-Perth who have been working around the clock as we have to control this outbreak. I'd like to shout out to the team at Cedarcroft. Infected staff who were in isolation started to come back to work this weekend, and we're very thankful for their return. This will assist in further stabilizing our staffing levels. Our intent is to have a significant contingent of staff on hand, especially higher staffing levels than what we would find in normal times. Jose Balke is a skilled regional director of operations leading the charge on the ground at Cedarcroft. She has previously successfully managed 2 outbreaks in Ottawa. She has a master's in public health administration and she's an RN. But beyond credentials, she and the team have worked extraordinarily long hours with care, compassion, and cooperation with medical and public health partners. Joshua Kuhl, Senior Vice President of Operations and one of the owners of our company, has joined her on the ground at Cedarcroft to provide senior leadership. It is my belief that Huron-Perth has been unprecedented in its response and cooperation. We want to thank these wonderful community partners who have come to our aid, including the Stratford Hospital, Wingham and Goderich Hospitals, Huron-Perth Public Health, the Southwest Local Health Integration Network, the Huron-Perth Healthcare Alliance, and the volunteer doctors who have been in the home. We understand the importance of direct communications to our staff. We have sent family letters and made calls and taken calls, but we haven't been able to reach out to as many as we would have liked to because of our staffing shortages. Today, we're setting up a hotline for the families to have a centralized point of communication. Our intent is to staff the number 24 hours a day. From 9 a.m. to 9 p.m., our plan is to get back to families within an hour. From 9 p.m. to 9 a.m., we'll get back to families within 4 hours. You can call us at the home's number, which is 519-273-0030. And lastly and importantly, we want to thank the community for the outpouring of support. We are receiving cards and emails of support. Restaurants are providing meals, and the homemade cookies baked with love have been amazing. I'd like to turn this back to Barb. Thank you.
Thank you so much. Let's turn now to Dr. Miriam Clausen, Huron-Perth Medical Officer of Health.
Thanks, Barb. Thank you, everybody, for joining us today. First of all, I would like to, on behalf of Huron-Perth Public Health and all our staff, also express our sympathy to the residents and family and staff at Cedarcroft who have been responding to a very challenging situation and also grieving the loss of 4 residents. The current status, and before I give update on the current status, I'd also like to express deep appreciation for the collaboration of all the partners who've come together locally to help support this facility, and you're going to be hearing from some more of them in a moment. So I'm going to give you numbers that are current as of this morning. Our website will not be updated until tomorrow morning. As Lily mentioned, there are 42 positive cases. 5 positive results were received yesterday, 4 from prevalence testing in residents and 1 from a new symptomatic resident, and no additional results today. And 18 staff. Our website shows 16. That's because 1 came in late Friday and is not yet on the website, and 1 staff is not a Huron-Perth resident. We were hoping to get the number hospitalized, but as you're about to learn, there have been people transferred to hospital as part of a decanting plan, so I don't have accurate up-to-date data on that, but we will supply that as soon as we can. And as Lily mentioned, unfortunately, sadly, there have been 4 deaths. Staff prevalence testing is planned for tomorrow for any staff who have been negative and asymptomatic all along. This is the 3rd round of prevalence testing, we can thank Perth Paramedic Services for their support in making that happen very smoothly on the ground. And just a word or two about the sort of work that public health has been providing. Our role is to assist facilities in preparing for cases and outbreaks, and then also assist them in responding. And the sort of work that we do is to provide information and resources and education around things like entrance and screening, universal masking, personal protective equipment, hand hygiene, physical distancing, outbreak planning, surveillance, management of cases, environmental cleaning, and auditing, just as a few examples. So that's it for me, and I'll turn it back to you, Barb.
Thank you, Dr. Clausen. Let's turn now to Andrew Williams, President and CEO of Huron-Perth Healthcare Alliance.
Thanks very much, Barb, and thanks to everybody who is on the call today to hear this update on this very important issue. Certainly echoing the comments that have been made so far. Our hearts and emotional support are out there for everybody involved in this. It is a very challenging situation for everybody, and we recognize that, and our sole focus is to support residents, support staff, provide a safe environment for everybody. It's been a very busy number of days, as has been pointed out. We have been focusing a lot of energy this past week on trying to stabilize the staff complement with staff going off ill. Obviously, the numbers available has dropped, so we've been able to redeploy staff from the LIN, from the hospital, from LHSC starting this week, which is remarkably beneficial and helpful. We have, through the agencies, tried to get staff in any way possible. So that has been a major focus for us. And I was at the home briefly this morning, and certainly we're starting to see staff come back, and it looks like we're in a much better position with on the ground individuals supporting the needs of the residents. The other major area of focus has been on clearly supporting the needs of residents. And we have two physicians actually on the ground today in the home. We have tremendous physician support. In the background, you're going to hear from Paul shortly. And their focus has been to assess all residents and make decisions that are in the best interests of the immediate health and well-being of the residents, and in the home's ability to support the residents that are there from a staffing perspective. So that has resulted in us transferring a number of residents from the home. Yesterday, there were 10 transfers from Cedarcroft to a number of area hospitals, Stratford, Ingersoll, Woodstock, Wingham, and Goderich accepted residents from the home. And I want to acknowledge and thank them for being as accessible as they are. We anticipate further transfers today. And again, it is based purely on the medical assessment of needs of the individuals and the staffing complement to support. It's doing what's in the best interests of the people who we're supporting today. And I'm very proud of how that has gone on. And Mike Adair from Perth Paramedic Services is on the line, and I just want to acknowledge the great work that they have been doing and being as responsive as they have been with taking residents throughout the county and actually outside of Perth County. Moving forward, our commitment is to stabilize the staffing complement. As I mentioned, we're in a better position now than we were last week. I want to give an absolute shout out to the staff who are there from Cedarcroft and from the HPHA and from the LIN, the physicians, the paramedics. It is remarkably impressive for me to go in and witness the caring and compassion that is being exhibited. And I know it's a very challenging time for everybody, but people need to be confident that the supports that are needed are being provided, and the needs of residents are paramount on all of our minds. So I'd be happy to obviously dialogue further, but I'll hand it back to Barb.
Thanks so much, Andrew. Let's turn now to Dr. Paul Gill, Huron-Perth Pandemic Leadership Primary Care Lead.
Yeah, thank you, Barb. So similar to Andrew and the team here, certainly for those 4 individuals that unfortunately we lost, our sympathies go out to those families. But I do want to spend a moment to thank the physicians that have stepped in from the point, from the point of identifying a need for clinical involvement in the home. We've had a number of physician stakeholders throughout the entire Huron-Perth region put up their hands and volunteer to become involved in the home itself. We do have, at this point, 2 physicians in the home today. We've also had 2 physicians in the home yesterday addressing acute medical needs, and I'll speak to that shortly as well. I do want to thank a number of different partners who have really stepped up to help create infrastructure. So as many of you may know, that long-term care homes have a lot of existing infrastructure with medical directors and staffing that are different than a retirement home setting typically has. And so to deploy physician staffing into a home to try to support residents in their home does mean that we have to activate and mobilize some infrastructure responses, such as getting oxygen into the home or medication supplies and equipment into the home. So to that end, I do want to send a thank you to Uric and Stratford Shoppers Pharmacies for mobilizing medications, the Ontario Home Oxygen Company for mobilizing it, and Perth EMS for mobilizing oxygen to help support residents in place, as well as the physicians across the sites that Andrew mentioned as well for accommodating and helping manage transfer of patients in a high quality and seamless way across sites as well. From our involvement when the clinical need was identified as being needed in the home, from that point yesterday, we were able to deploy, again, 2 physicians at that point. As Andrew has mentioned, our assessments yesterday led to the movement of 10 patients out of the home. Really, our response yesterday focused on identifying the acute medical needs yesterday and resulted in 5 patients who were COVID positive being moved out to other centers, and 5 who had acute medical needs that were moved out as well, but were COVID negative. We continue today to have the patients assessed and have continued to identify patients that we, for staffing reasons, I believe will work towards seeing if we can help move them to a different center, namely to improve staffing ratios at this point. So the patients that we're looking at today have mostly been individuals that don't have as urgent an acute medical need as the folks yesterday that have already been moved. So I'll pause there and certainly open it up to questions as well.
Thanks so much, Dr. Gill. Okay, so that's it for our speakers. So for members of the media, please unmute yourself. Let us know your name, media outlet, and who your question is for. And we're okay time-wise, so there will be time, for questions. So please go ahead and unmute if you have a question.
Hello, it's Scott Miller from CTV News in Wingham. Thanks everyone for making this happen. Much appreciated on a Sunday. I guess I just had, we'll just start with most recently, probably for Dr. Gill. Just curious about, I think someone from the outside, again, I'm not a doctor, but someone from the outside might question why shouldn't people with COVID stay in one place and people without COVID stay in one place? Like, why removing some patients with COVID and some without? Why are we essentially spreading out those patients to different hospitals?
That might be a better question for Dr. Clausen, our public health officer. So I'll defer to her expertise here.
Yeah, no problem.
So thanks for the question. So absolutely, the preferred approach in an outbreak in a congregate setting would be to provide resources to keep all the residents in their home, because it is their home as well, and receiving the care and the support they need, and minimizing the risk of introducing infection into other settings, as well as it preserves hospital capacity. So that is the preferred approach. Even so, some patients are not able to be cared for in a long-term care home or a retirement home when they become ill, and they could be transferred. However, if we're no longer able to provide safe care in the facility because the demand is outstripping the capacity, then decanting is the next option. So that is why this plan was developed, to assess residents and transfer based on their care needs and based on the capacity in the system. And I think everybody does know that capacity, especially around skills such as PSWs and resident aides and so forth, is tight in the system. And during an outbreak, I think everybody also knows, as has been discussed, the need for staff goes up because the workload goes up with all the enhanced outbreak measures. So in the interest of keeping every resident safe and receiving the appropriate care, that this decanting is happening. At the same time, there are continued efforts to put the resources into the home so that they can provide the care needed to the remaining residents and get ready to receive the temporary transfers back to their home once the situation is stabilized. And I do really want to acknowledge Huron-Perth Healthcare Alliance, Andrew's team, Paul's leadership, Dr. Gill's leadership with the primary care physicians, the LIN staff who've been working together to make that happen.
Thank you very much. If I could, one follow-up, and then I'm happy to let someone else ask questions. But I mean, I'll ask, I think I know the answer, but I mean, people are going to wonder, is someone with COVID now at my hospital in Wingham or in Ingersoll? Are you willing to say where the people went? Like 5 people with COVID went to Stratford, or they're spread out, or like where exactly the COVID patients ended up in hospital?
You know, I don't have the answer to that, but what I would say is that anyone who accepted a transfer had the proper capacity to receive that person, whether COVID positive or not. And our hospitals have been, you know, since wave 1, they have been, I'll let Andrew answer this question, but they've been preparing for this and dedicating space to receive COVID positive patients.
Yeah, thank you very much. Yeah, if anyone else has questions, I'll let them jump in.
Andrew, go ahead.
Well, I was going to echo Miriam's comment, you know, that all the facilities that we've connected with have all of the right protocols in place, and it's been a major focus for all of our hospitals, and certainly within the HPHA. You know, we have COVID positive patients here now, and they are being cared for in all the appropriate ways with PPE, personal protective equipment. We're very transparent with our staff. So we're very confident, Scott, that all of the transfers are in a very appropriate, safe manner at all the sites.
And I would just go beyond that as well to ensure that the physicians on the ground, when they're doing their clinical assessments as part of their work, they're actually trying to match the care needs of the patients to the sites that patients will be transferring to, and ensuring that physician to physician handover and skill sets to manage those individuals are being communicated in real time. So, you know, it's been a tremendous effort on the ground with the team in the home, actually accommodating and aligning and coordinating the response.
I'd just add to that too, from the paramedic service perspective, that the actual act of the transfer itself is well coordinated with physicians as well as the hospitals, and all the protocols and processes that take place at both ends are in place to ensure the safety of everyone involved, including the patient.
Thanks, Mike. So the last speaker was Mike Adair, the Chief of Perth Paramedic Service. Okay, other questions from media outlets?
Hi, it's Galen from the Stratford Beacon Herald. I just wanted to go back to maybe explain a bit more what that threshold is for a resident to be transferred to a local hospital. I know you talked about, you know, hospital capacity and resident need, especially residents with acute medical conditions. Can you sort of explain that a little further, flesh that out a little bit?
Sure, Galen. So from a clinical perspective, really, it's fairly complex. It doesn't come down to a simple metric or you know, a single vital sign or anything like that. Really, it is a discussion between the clinician and the patient themselves, whether it's a factor of goals of care, you know, desire to be transferred to another location, dependent on whether or not the care needs of that patient can be met in the home. Initially, in the home, infrastructure-wise, we did have some limitations where, medications that we could have supported some of the patients in the home with don't typically exist in a retirement home setting. So, getting those things mobilized into the home, had those things, had those things been there earlier, which typically isn't the case in a retirement home, we may have been able to circumvent 1 or 2 transfers. But all in all, the timing of the transfers really is dependent on a multitude of factors that are both patient symptom-based as well as goals of care-based, along with clinical decision-making factors and staffing factors. So there's a lot that goes into a decision to move a patient from the home. And ultimately, our efforts, as Miriam, Dr. Clausen had suggested earlier, our efforts are really to ensure that we up skill, up staff, and up support with supplies and equipment, the home itself, to provide care in place with the highest quality and support that we possibly can. And only when there's a concern of those issues being met, or patient safety needs to be moved to a different location because those infrastructure supports are just not available skill set wise or device wise, are patients being considered for transfer.
Right. So if I'm understanding it correctly, this is sort of, like you said, a temporary measure to sort of place those who are at most risk of, becoming severely ill if they come down, or if they've already got COVID, in a setting where they can be adequately cared for, and then try to bring that not standard, but the resources that are needed at Cedarcroft back up to a point where ideally they can be brought back into the home and cared for back in their home setting.
I think we're doing all those things concurrently. So
yeah.
So certainly, Galen, I think you've captured it to a degree. There are patients, obviously, if we're running into a staffing ratio issue, some patients may continue to be moved, not because of a pressing medical need, but because they are higher risk, they are COVID negative, they are asymptomatic, but for the purposes of matching staff supply to the needs in the home, that creating a better matching of that staffing ratio may actually support us as well. Obviously, in our community, as was discussed earlier as well, human resources are a challenge, right? So we know in the Canadian landscape, 18% of the population lives in rural environments, but only about 10 to 12% of the physician supply typically does. And so trying to get staffing resources from a clinical or a physician perspective can be challenging to mobilize all those resources and then still have our day jobs where we need to support people in their community settings, keep elective procedures, office visits continuing to go. So some of those decisions are on the basis of staffing and not necessarily purely due to patient necessity. But again, when the situation is stabilized, the intent is to move those patients back into the home when certainly it is felt that we can provide a high quality of care to do so.
Right. And I know you mentioned, or someone mentioned, that there were 10 patients transferred yesterday, more today. I mean, I imagine these transfers, they take a lot of resources to undertake. Is there like a limit to how many patients you're going to be transferring on a daily or a weekly basis? And I guess, how do you choose, I mean, we sort of talked about that, but how do you decide who fits it within that limit?
So in the system, there are some constraints based on bed capacity. So it's not necessarily that there's a limit or a number that we're shooting for or targeting. It really comes down to what are the patient needs and how do we best look after the patients to the highest quality of care that we can provide. So, I think if you asked system partners, how many beds do you have available? We're all stretched thin. But if you highlight and say, this patient has a care need and really would benefit, that it will change their outcome by being managed in a different center. We've seen that our partners have stepped up. We've seen hospitals where there is no bed supply, create bed supply, whether it means overstaffing or creating staffing to create that bed supply. So certainly, from our perspective, the care needs through the system, and Andrew certainly, I'm sure, will share experiences working with the CEOs across the different hospitals as well. The willingness of our partners to step up to the plate and actually create capacity dependent on the needs of the patient has been our focus, and certainly our partners have stepped up in that light.
Thank you, Paul. Andrew, did you want to add something?
Yeah, I can just add, we have a daily lens on all the beds across the region, so we know the capacity of all the sites. We will reach out to organizations. We certainly gave hospitals a heads up a couple of days ago that we were going to be looking at this, and so they started to employ their protocols to free up beds if they could. So it really is a system focus, and I want to give a shout out to our home care and our LIN providers, because they've been working with the hospitals to free up beds in the hospitals to allow us to accept residents from Cedarcroft. So it really is a team effort to try and make sure that we're able to meet the needs of those individuals who have the highest care demands.
Right. So it is resident first approach, I guess, eh?
Yes.
Excellent. Thank you very much. I'll turn it over to whoever else has questions.
Thanks, Galen. Okay, any other questions from other media outlets?
I'll jump back in if no one else does. I guess my first one was, I guess, is this precedent setting? I mean, I know it's the first time it's happened in Huron-Perth. Is this common practice across the province, or is this one of the first times this plan has been enacted? And sorry, I don't know who to direct that to, but whoever thinks they have an answer to that would be great.
Andrew,
maybe I'll start, Scott. I mean, this clearly is the first time this has happened here locally, and we actually were having a conversation this morning about making sure we track lessons learned so that we can sort of build on the successes that we've had and the challenges, and make sure that as much as we can, we share with others. From experience across the province, I would say every single time there has been an outbreak of this nature, the same lens has been applied. What's in the best interests of those who are actually experiencing the outbreak? And there would be movement for sure between various institutions and organizations, and it would depend on the scope of the outbreak. It would depend on the staff availability, and as we pointed out today, that's one of the major drivers of the decisions that we've been making is ensuring we have that right staff mix to support the acuity of the residents. So it's the first time here locally, but certainly not across the province.
No, thank you. I appreciate that. If I could, I'll ask another follow-up. So we know kind of essentially with 42 positive tests with residents, that's roughly about half the number of residents at Cedarcroft. What's the percentage of staff that have become infected? I suspect that's a question for Lily. I don't know if she's on or Dr. Clausen.
I could answer that. Can you hear me?
Yes, I can hear you, yes.
Sorry, we've had 18 staff infected with COVID. 5 have been resolved.
And so is that, what percentage of your staff is that? Is that half of your staff? Is that 1/3?
I think probably it's a third, would be safe to say.
A third, yeah. Yeah, a fair estimate. No, I appreciate that. And I'll ask one other question if I could, and this is potentially an unfair question, but I think I have to ask it because we're going back to, if I use Greenwood Court as an example, we had a similar outbreak there that seemed to be a little bit more contained. I mean, this is clearly the largest outbreak. What's different this time? What's gone wrong, I guess?
It's Jeff Reno.
And again, I'm sorry, I don't know who that might answer, but yeah, I'll throw it out there.
It's Jeff Reno here, administrator in Rissuther, Villa, and Mitchell. I think one of the key differences is that Greenwood Court was attached to a long-term care home setting. And so there's obviously a difference between retirement home and long-term care home. Long-term care homes typically have significantly more resources in which to help combat these things as they happen. And so, in the long-term care setting, we've known that it was going to hit long-term care. Wave 1 was particularly hard for long-term care. And so we've been planning together, we've planned together, talking about IPAC across the region. And so we're fairly tight knit in terms of that. And I think that was one of the key mitigating differences.
And perhaps I'll just add a point or two to that. You know, I don't think we'll ever know exactly, but just to mention that the risk factors for this level of transmission in a facility, you know, one of the key challenges is that this organism has a 14-day incubation period. So if you have one case, every single contact of that case could become sick as far as 14 days out, which is a long incubation period. So that can make it very, very challenging. And as Jeff mentioned, this is a high-risk population in a closed community. And this particular retirement home, as has been said a couple of times, many residents stay past the point that you know, that you might have seen them transfer into long-term care homes, so they have higher needs. And then, as we have mentioned a couple of times, the risk factor is just the increased demand on staffing. During the first wave, a lot of healthcare facilities had suspended many services, so there was more capacity in the system to redeploy. During the second wave, you know, hospitals are doing surgeries, and you know, healthcare facilities have less wiggle room.
Okay. Yeah, thank you very much. And I'll ask one other question if no one else has one. I mean, I've had some family members reach out to me and express their concerns about this clearly. And one of their concerns, and I don't know if it's the true or not, but that's why I'll ask, their concerns were about maybe part-time staff or staff that were going into the home and then they had go to, I know you're not allowed to work in another long-term care home, but we're going to work at Tim Hortons, or some high school kids that would be helping out there and then would go to school. I don't know if that's accurate or not, but that's what some family members have told me that they had heard were happening. So I'll ask if that was happening, and if that was a contributing factor or a concern.
I can answer that.
Thank you.
Our company has had higher standards than what government has done federally or provincially or even locally throughout this COVID. So by that I'm saying that before government thought of single site employer, I implemented it across the country for my employees. I've implemented it so that we would only have them coming in and not working at the McDonald's or at the Dairy Queen. So that has been something that we've been doing for a very long time. And again, at this facility, as recently as 2 weekends ago, I was on with the union saying, we will pay extra money to have that happen here out of our pocket, because as you all know, we are not subsidized by anyone. So we are paying extra money for people to do that. An extra $2 premium has been implemented by us for all staff members, all of our staff members that are coming into work.
All right, yeah. And sorry, just so I understood that. Sorry. I just so I clarified that. So that means that you didn't have people working at Cedarcroft and then going to work at Tim Hortons.
Well, I think it's very common within this industry. I mean, people do work at 2 different locations. Before COVID, I think a lot of people did, but during COVID, no.
Okay. Yeah. No, thank you.
Not in our buildings.
Gotcha. No, thank you. And sorry, someone else wanted to chime in. That's cool.
Scott, yeah, I was just going to add, it's Andrew. You know, one of the major focuses, obviously, throughout the pandemic has been infection prevention and control, and ensuring we have the right practices in place. And one of the challenges we all face, quite frankly, is as we're trying to bring staff in, oftentimes we're getting staff from agencies. They come in at the last minute. They may not have the comfort level that we think is necessary. So we've deployed an infection prevention control professional right into the home, who is ensuring that any person coming in there who's working has all of the right skill sets from an infection prevention and control perspective. Because, you know, as you point out, people are moving around the communities, and we want to make sure that when they come into this environment or any environment, hospital related, that they're following all the right protocols and they have all the resources that they need to be safe. So that's been a fundamentally important piece of this initiative over the last number of weeks, is focusing on that and making sure the staff are comfortable with the supports that they have.
Thank you very much. I appreciate that. Yeah. And anyone else can ask some questions. Thank you.
Oh, you keep saying that, Scott, but you're the master of squeezing in the question. So
I do.
no,
That's true.
no, it's
Hey there.
good.
Hey there.
Go ahead, Roland.
Okay, perfect. It's Roland Archer from 100.1 The Ranch in Listowel. My question is actually further to Scott's about care workers, PSWs, whatever, coming in from possible hotspot locations, because obviously we live in a community where people commute sometimes an hour to work. So what precautions are we taking for these staff that are coming in to Stratford or to Mitchell or to wherever, because it's as their numbers go up in Kitchener or in wherever, people are possibly commuting from there. Like I'm assuming COVID tests are done. They have to come back negative before they step foot in buildings. Are there any other things contemplated or on the horizon?
So, I mean, I can start on this one. Currently, for long-term care homes and retirement homes, there is regulation in place, further to the Reopening Ontario Act, to not allow healthcare staff to work in more than one healthcare facility. And that's because that's where the risk is greatest. Because that's where we take care of sick people. But in terms of preventing staff, I mean, there are lots of staff that live in Huron-Perth that work outside of Huron-Perth and vice versa. I think that the real foundational piece there is the proper IPAC training that Andrew was talking about, the infection prevention and control. Because if staff are, if we're all doing the daily screening and staff are doing the universal masking, and when cases are identified, you're wearing the proper PPE in a consistent and proper manner, then that can be done safely. So that's really what Andrew was getting at, was getting that IPAC support there, so that anyone coming in, who's already been screened and shouldn't have any identified risk, is also using proper PPE consistently and appropriately at all times. And that's, I think, the best approach to mitigate that risk. And I don't know if anyone else has anything to add.
I could just add that we have a very intensive protocol in place for screening for people coming into the building. So we check temperatures. We have a list of questions that are asked when someone's going to enter any of our buildings, which I think is helpful. I also believe that we're not sure how it came into the building. It could have been a family member, someone visiting. It could have been, no one really knows. So, I mean, it's just the screening that we do that we're very keen on, and we've put in place, and we're very, very strict about it, as well as the PPEs. Proper PPEs play a huge role in stopping this or controlling this.
Great, thank you. Are there any other questions from media?
Hi there, Emily Stewart from the Stratford Local. I'm just wondering, since I'm understanding, and correct me if I'm wrong, that this is a temporary measure, what would need to be done for the residents to move back to Cedarcroft?
Maybe I can start, Emily, it's Andrew. Obviously, we need to stabilize the staffing. We need to ensure we have the right complement of staff. Number one, for the residents that are there currently, and if we're going to bring residents back to support them, we will definitely want to be on top of the outbreak, and that's a key area of focus right now with public health, and obviously the care needs of the individuals who we have transferred to other locations would need to be appropriate for them to go back. So there's a number of things that we would look at. But as has been reinforced, this is a temporary measure, and we recognize that these are these residents' homes, and we want them there in their homes, but we want them there safely. So there'd be a number of checks we'd have to tick off before we were able to say, now we can send people back.
Yeah, and just to piggyback on what Andrew was saying, so public health is continuing in the daily outbreak meetings with the facility to assist them in containing the outbreak. So the part, one of the next key strategies is to complete the third round of prevalence testing by testing the staff, and that should happen tomorrow.
All right, thank you so much.
Thanks, Emily. Any other questions from media?
Barb, if it's okay, I do want to just make one comment as well, just for the sake of folks understanding. From a response perspective, the number of individuals and stakeholders across the system, whether it's the triads or the triads at the Southwest level, but individual partners, sector stakeholders meeting around this with last minute, hey, urgent, we've got a meeting request for 45 minutes in 10 minutes to help support some decision making, has been become fairly routine at this point. And we will have ongoing meetings as a team sort of managing the outbreak where it is. And we continue to have those meetings on a daily basis. So certainly, as the situation evolves, you can be sure that the leadership around this is meeting on a very, very regular, if not multiple times a day, at least a daily basis, to reevaluate where we are every single day. So I just wanted to share that piece as well, and thank again all of the different partners across the system who have really stepped up to be involved in those shared decisions and to support from a decision-making perspective their capacities, their availability, and how we may need system stakeholders to adjust whatever we need them to adjust, whether it's routine protocols for how drugs are delivered into a community setting, or dropping off oxygen from an EMS or whatever it may be. So there's been a lot of willingness in the Huron-Perth communities for adjusting on the fly to the requests of the leadership at this table, to really adapt and do things a little bit differently than the system typically supports, really in the best interest of the patients and the individuals at Cedarcroft.
Great, thank you. Okay, last call for final comments or final questions. Okay, thank you very much, everyone, for carving out some time on a Sunday to get an update and to give updates. Appreciate it. For media, we will be sending out notes and Q&A today as a summary of this. And as I mentioned at the beginning, it's been recorded and will be uploaded to our social media platforms. All right, thanks, everyone, and have a good rest of the day.
Thank you.
Bye.
Bye.